You will gain knowledge and skills to help you better care for patients with psoriatic arthritis, psoriasis, and axial spondyloarthritis. Specifically, our panel will talk about the clinical features, classification, and epidemiology of these diseases. You will also hear the patient perspective and have the opportunity to ask questions during this live webinar. Please use the chat function to enter your questions throughout the talks. Next slide, please. Now, I would like to introduce our agenda and speakers. In the order of appearance, you will first hear from our patients. In the beginning of the psoriatic arthritis session, we have Suzanne Grieb, who will share her perspective. She is a patient research partner. In addition to that, we will also hear from Wendy Olster. Then we will hear from Dr. Daphna Gladman, who is professor of medicine at the University of Toronto and director of the psoriatic disease program there. Following their presentation, we'll have a Q&A session, and then we'll go to psoriasis, where I will talk to you about the clinical presentations and epidemiology of psoriasis. And following that, we'll have the axial spondyloarthritis session. That's going to be presented by Dr. Mohammed Asim Khan, who is Professor Emeritus of Medicine at Case Western Reserve University. In addition to that, we will also hear from Dr. Dennis Poduni, who is Professor of Rheumatology at Charité Universitäts Medizin, Berlin, Germany. Next, please. We would like to thank Pfizer for the support of this educational activity. Next. So first, we'll begin our session on psoriatic arthritis. Next, please. We'll start with some pre-questions. So please select which of the following statement is true about enthesitis in psoriatic arthritis. Is prevalent in about 1/3 to 1/2 of the cases? Clinical assessment reliably correlates with imaging. Enthesitis is always the initial clinical presentation or manifestation of this disease. Tenderness at multiple entheses points may cause confusion with a diagnosis of fibromyalgia, or it's also the most commonly seen around the knee. Okay, and with that, we can take a look at the responses. Okay, so as you can see, is prevalent in about 1/3 or 1/2 of the cases, being the most common answer, followed by tenderness at multiple entheses points may cause confusion with diagnosis fibromyalgia. We will go over the answers to these questions at the end of the psoriatic arthritis session, so stay tuned. Next, please. Second question. The main pathology in dactylitis is it tenosynovitis, bone edema, synovitis, enthesitis, or all of the above? You have about 15 seconds. All right. Okay, looks like the majority chose all of the above. Next, please. All right, so let's first hear from Wendy and Suzanne about their experiences, and we really appreciate their participation in this conference to share with us their journey.
Hi, I'm Suzanne Grieb, a patient research partner from the United States. I first began experiencing psoriasis about 20 years ago and was diagnosed with psoriatic arthritis in 2014.
Hi, I'm Wendy Olster, a patient research partner from the Netherlands. I had my first symptoms when I was 14 years old and was diagnosed with psoriatic arthritis about 3 years later.
So we both had a considerable gap in time between our first symptoms and our diagnosis. What was your disease history and diagnosis like in the Netherlands?
Yeah, so my diagnosis with psoriatic arthritis was not easy. I was just 14 years old when I began having a lot of pain in my hips and in my neck. And I visited a lot of pediatricians and orthopedics, but none of them could really figure it out. They even told me I was too young to have a type of arthritis. And then a few years later, I finally visited a rheumatologist who diagnosed me with juvenile arthritis, as the joint cartilage of my hip was broken down due to all the flares. It was such a relief to finally get my diagnosis. And a bit later, I also started to develop psoriasis around my elbows, and they diagnosed me with psoriatic arthritis. So, Suzanne, our situations are quite different in regards to the order of symptoms. How was your psoriatic arthritis finally recognized?
Yeah, so I had seen multiple dermatologists over the years for my psoriasis, but had never heard of psoriatic arthritis. And over the years, I had a lot of pain in my feet, probably starting in my late teens and early 20s. And then after I had my son, I started experiencing really bad flares on my skin, extreme fatigue, leg pain, and then my postpartum depression turned into chronic depression. And through work, I just happened to be invited to conduct focus groups with psoriatic arthritis patients for a rheumatologist at my institution. And during these focus groups, I realized that these patients were describing my situation. And so I then saw a rheumatologist and was diagnosed with psoriatic arthritis. And it was all a bit surreal because previously we had been dealing with everything individually. And it was almost mind-blowing to me that my issues were connected and that there was some underlying cause that could address them, because this had never been suggested to me. And so our stories are somewhat switched in order, but they do share like this issue of disconnect. Looking back on your experience, what do you think the trouble was with sorting your psoriatic arthritis out, and how would you like to see the diagnostic process improved for others?
So for me, it would have helped if there was a more holistic perspective between doctors, including rheumatologists and orthopedics and also dermatologists. I think if there was a better multidisciplinary approach, they would have diagnosed me sooner. And if I got the treatment earlier, I also wouldn't need the hip replacement that I need now.
Yeah, I agree. I would say the lack of the holistic perspective or system really hindered my experience as well. Part of that is just a result of the US healthcare system, but greater education around psoriatic arthritis, I think, could at least help some.
Yeah, I totally agree. My doctors dismissed the idea of arthritis because of my age, and I think greater education could resolve this. Thank you all for allowing us to share our stories and experience as patient research partners.
Thank you.
I'm Daphne Gladman from the University of Toronto. I'll be talking about clinical features, classification, and epidemiology of psoriatic arthritis. Psoriatic arthritis has been defined by Moll and Wright as an inflammatory arthritis associated with psoriasis, usually negative for rheumatoid factor. Because of its associated features, including spondylitis, enthesitis, dactylitis, iritis, mucous membrane ulcers, urethritis, and other extra-articular features of spondyloarthritis, it's been grouped with the spondyloarthritis. Moll and Wright described 5 clinical subgroups of psoriatic arthritis. These include a symmetric polyarticular disease, which in their series accounted for 15% of the patients. Arthritis mutilans, a very deforming form of arthritis, occurred in 5% of the patients. Predominant distal joint disease occurred in 5% of the patients. The majority of the patients had oligoarthritis, which means 4 or less affected joints. And 5% of the patients had isolated spinal disease. Moll and Wright also recognized the presence of dactylitis, which is swelling of the whole digit, that occurred in about 40% of the patients, and enthesitis, the inflammation at the insertion of tendons and muscles into bone, which occurred in about 50%. Up until 2006, we did not have any common classification criteria for psoriatic arthritis. However, a study that was done, which included patients with psoriatic arthritis and patients with inflammatory arthritis that was not psoriatic arthritis, demonstrated that in patients who have inflammatory musculoskeletal disease, either peripheral joints, enthesitis, or spondylitis, if they have current psoriasis and one of the following, which is dactylitis, psoriatic nail dystrophy, a negative test for rheumatoid factor, or radiological evidence of just articular new bone formation, which cannot be an osteophyte, they could be classified as psoriatic arthritis. If they have a past history or a family history of psoriasis, they need 2 of these points. If they have no psoriasis, they need 3 of these points. 3 out of these points in a patient with inflammatory musculoskeletal disease identifies a patient with psoriatic arthritis with 99% specificity and 91% sensitivity. A number of items have been found to be associated with the development of psoriatic arthritis. One of them is obesity, and as we can see here, with increasing bone mass index, there is an increasing relative risk of developing psoriatic arthritis, and as you can see from the figure on the right, that risk continues through 10 years of follow-up. A number of environmental exposures have been identified as being associated with psoriatic arthritis compared to psoriasis patients. This is a study based on the University of Toronto cohorts, and what it demonstrated is that injury, infections that required antibiotics, and occupations that involved lifting loads were associated with the development of psoriatic arthritis, whereas smoking seemed to be protective. No association with alcohol consumption, vaccination, stressful life events, or female hormonal exposure was detected in this study. The association between psoriatic arthritis and smoking has been controversial. The original study by Pattison et al., based on a British cohort, showed no association. However, another study from Britain, based on the National Health Survey and using PACE as the case ascertainment tool, identified current smoking as associated with psoriatic arthritis with a relative risk of 1.62 compared to psoriasis. However, 2 other studies demonstrated that smoking was either protective or delayed the onset of psoriatic arthritis among patients with psoriasis. The incidence of psoriatic arthritis is higher than we used to think. This is a prospective study in patients with psoriasis followed at the University of Toronto. They come to the clinic if they have psoriasis and no evidence of arthritis as determined by a rheumatologist. 51 of 463 patients developed psoriatic arthritis over 8 years of follow-up. The annual incidence was 2.7%. Multivariate analysis of baseline variables revealed that severe psoriasis, low level of education, use of retinoid medications were associated with the development of psoriatic arthritis. A multivariate analysis of time-dependent variables identified the presence of nail pitting and uveitis as associated with psoriatic arthritis. Importantly, what that study taught us, as we can see in the figure, that the risk for psoriatic arthritis is linear, and we must continue to be vigilant about looking for psoriatic arthritis in patients with psoriasis, even after 20 or 30 years of disease. The population incidence of psoriatic arthritis has varied remarkably over the years and in different centers. This is a slide showing the annual incidence of psoriatic arthritis per 100,000 person worldwide, and we can see that it varies from 0.1 in Japan to 23.1 in Finland. The population prevalence, and this is percent, has also varied significantly from 0.04 to 0.67 in a study from Sweden. The most recent study from Canada revealed a prevalence of 0.17. We're moving to talk about the clinical features. So polyarthritis, 5 or more inflamed joints, can be either symmetric or asymmetric. Symmetric may mimic rheumatoid arthritis, but we must remember that DIP joints are involved in about 50% of the patients. Symmetric disease is usually more severe and associated with poorer prognosis. The more the number of joints, the higher the risk of progressing damage. And fusion of interphalangeal joints and wrists may occur. The asymmetric arthritis means 4 or less joints. It can be either oligoarticular or monoarticular, can involve any of the joints, and it often is associated with dactylitis. Dactylitis presents as a ray distribution, as we can see in the figures here, in both the fingers and the toes. It presents with swelling and erythema of the entire digit. The joints are painful, and there is often limitation of range of movement. It is a negative prognostic factor in the sense that digits with dactylitis are more likely to have erosive changes, and it adds work disabilities. Enthesitis occurs in almost 50% of the patients as well. The Achilles tendon, plantar fascia, elbows, costochondral joints, and patellar tendons can be affected. In a study done at the University of Toronto between 2008 and 2014, 281 of 803 patients had enthesitis based on the Spark enthesitis index for a prevalence of 35%. The incidence in those who did not have enthesitis at presentation was 0.9% per year. Mean number of sites, 2. Most common sites, Achilles tendon and the lateral epicondyles. Actively inflamed joints, tenosynovitis, dactylitis, pain, and less clinical damage were associated with enthesitis at any time, and the risk for developing enthesitis were high body mass index, actively inflamed joints, and younger age. The axial disease may affect 5% of the patients as a singular involvement, but up to 40% of the patients together with peripheral involvement. It is associated with B27. Patients may be asymptomatic. Asymmetric sacroiliitis and spondylitis can occur. Neck is commonly involved. Spondylitis may be seen without sacroiliitis, and importantly, non-marginal syndesmophytes are common. The DIP joint arthritis is frequently associated with nail changes. It occurs in general in about 53% of the patients, but in only 5% as a singular entity. It can be symmetric or asymmetric. It's frequently associated with distal erosion, and it may be associated with significant loss of function. Patients with distal joint disease need to be distinguished for inflammatory osteoarthritis at the DIP joint. Since psoriasis and osteoarthritis frequently exist, those patients may be difficult to differentiate. In favor of psoriatic arthritis is soft versus bony swelling, other joints that might be involved, nail changes, radiological appearance, osteophytes versus erosions. In favor of osteoarthritis, family history, again, the type of other joints involved, and the radiological appearance help us distinguish between psoriatic arthritis and distal osteoarthritis. So here are some pictures of the differences in radiological appearance. So the clinical picture is from a patient with osteoarthritis, demonstrating both Heberden's and Bouchard's nodes, and again, the squaring of the first carpometacarpal joint. That can be seen on the X-ray below. On the other hand, in psoriatic arthritis, we can see the typical pencil and cup change that we can see in both of those figures. Arthritis mutilans, luckily, does not occur in a large percentage of the patients, and it seems that its frequency has been reduced over the last several decades. It frequently involves the DIP and P joints of the hands in a polyarticular pattern. Osteolytis and telescoping of the digits may occur, Association with severe erosions and deformities may occur, and you can see that in these figures, both in the clinical picture and in the X-ray picture, this patient lost the distal two phalanges, and there is significant functional disability. The nails occurs in 80% of the patients, as opposed to only 40 to 45% of patients with psoriasis uncomplicated by arthritis, and they include pitting, transverse ridging, onycholysis, hyperkeratosis, and nail yellowing. There are a number of items that can differentiate psoriatic arthritis versus ankylosing spondylitis versus rheumatoid arthritis, as we can see here, both in terms of the joints involved, presence of DIP joint disease, the presence of dactylitis, presence of enthesitis, the type and presence of erosions, presence of non-marginal and asymmetrical syndesmophytes in psoriatic arthritis compared to marginal symmetric in ankylosing spondylitis, and having no such involvement in rheumatoid arthritis. Sacroiliac involvement, again, may be asymmetric in psoriatic arthritis, but symmetric in ankylosing spondylitis. Rheumatoid factor, or CCP, are positive in rheumatoid arthritis and only in the same percentage as the general population in the other two conditions. There are multiple genetic risk factors for psoriatic arthritis, and B27 is certainly seen in axial disease. It's also seen in ankylosing spondylitis, and in rheumatoid arthritis, it's the shared epitope of the DR alleles. So in summary, we can say that many patients with psoriasis and psoriatic arthritis have family history of either psoriasis and psoriatic arthritis. In fact, usually 40% of the patients. Psoriatic arthritis is exemplified by asymmetric joint distribution. However, when a lot of joints are involved, it becomes symmetric. DIP involvement occurs frequently in at least half the patients of psoriatic arthritis, and we must distinguish it from osteoarthritis. Dactylitis is a common occurrence, occurring in almost 50% of the patients. Nail involvement commonly occurs in psoriatic arthritis. Generally speaking, they are negative for rheumatoid factor and CCP, although, as I mentioned, they could be present in older individuals. Asymmetric syndesmophytes and sacroiliitis occur commonly in patients with psoriatic arthritis. And X-rays showing erosions, osteolysis, periostitis, in the absence of osteopenia, are typically seen in psoriatic arthritis.
Great. Thank you, Dr. Gladman. That was a great presentation, and I know every time I hear from you, I always learn something new. So thank you for that. Now let's go to post questions and let's see how our audience did here. Next, please. All right, so it's the same questions, and let's take a look. Which of the following statement is true about enthesitis in psoriatic arthritis? And I'll have you go ahead and take a look at the answer choices here. And you can select more than one. Okay, let's go to the responses. All right, so again, most of you chose the first one. Is prevalent in about a third to 1/2 of the cases, and that the tenderness at multiple enthesitis points may cause confusion with diagnosis of fibromyalgia. So both of those are correct answers. Next. There we go, as you can see here. And then we'll have Dr. Gladman speak to that during our question and answer period. Next slide. All right, the main pathology in dactylitis is, can please select your answer. All right, the polls will be closing. Okay, so now 83% of you said that's the correct answer. Next slide, all of the above. And as you can see, that is the correct answer. So wonderful. Thank you very much for your participation in those questions. And please, as well, if you have any questions, just as a reminder to the participants, you can put those questions in the chat and we'll answer them in the question and answer period. So with that, we will go to Suzanne and as well as Dr. Gladman for the discussion part. So we have a number of questions that have rolled in. And first, I just wanted to see if Dr. Gladman had any comments on those questions that were asked during the post question period.
Yeah, I think people did very well in terms of answering those questions. I just want to remind people that there really is not a correlation between the imaging and enthesitis in many cases. This is one of our biggest issues in terms of assessing enthesitis and recognizing what is really the gold standard. Should it be the imaging or should it be the clinical examination? So yeah, we need to remember that there is actually a discrepancy, and it's been shown by a number of studies. But otherwise, I think people have actually done well and obviously learned something from the presentation.
Yes, absolutely. I thought they did really well too. All right, so I have a question for Suzanne, and then we'll go over a few other questions for Dr. Gladman afterwards. So Suzanne, you had talked about wishing there's more coordination, between rheumatologists and dermatologists, and if we just focus on the care of kind of rheumatological care in the U.S. and from a patient's perspective, if there's one or two things that you can change about how it's delivered in the U.S., and I'm sorry, this is a little U.S.-centric question, what would it be?
Yeah, I think possibly just the communication around the fact that there's so much that can go on in our bodies due to the inflammation and the fact that things like fatigue and depression and fibromyalgia are all potentially part of our disease and part of that, biological response to our immune system acting the way it's acting. I think understanding the underlying issues of the disease is really helpful, and it definitely helped me, not only deal with my issues, but also understand it and that we deal with it biologically, but also kind of emotionally as well.
Great, thank you. So hopefully maybe one of these educational pieces we can, make it patient friendly and maybe even make that available to patients in the future. So thank you, Suzanne, for that. Okay, so Dr. Gladman, we have a question from Dr. Gupta from Michigan. Where would you exactly inject steroid in an isolated dactylitis patient? Is it into the PIP or DIP joint or the flexor tendon sheath?
Very good question, and it actually is quite variable depending on the patient in front of you. If the joints are really swollen, I usually inject the joints. If the tendon appears to be swollen, or certainly if there's a tendon nodule, I would inject into the tendon sheath. And the truth is, I've injected in the same patient both the tendon sheath and the affected joints in order to get things under control. I mean, if they only have an isolated finger, you don't want to start putting them on a lot of systemic medications. And if you can get away with just injecting the appropriate sites, that would work.
Great. Thank you for that tip. And our next question is, Dr. Gladman, you talked about axial psoriatic arthritis and some of the asymmetric presentation in the sacroiliac areas. So with the lack of consensus on the actual definition of axial psoriatic arthritis, and also coming from a dermatologist's perspective, I know I'm always confused about the definition. Any tips on how to sort of diagnose axial PSA for those of us who may not be rheumatologists?
So stay tuned. There is an international study that's going to start shortly that hopefully will give us the exact answer in a year's time. But for the time being, it is very difficult because many of our patients with psoriatic arthritis who have axial involvement actually do not present with pain, whether it's because the pain in the peripheral joints is over-consuming, or whether they actually don't have pain in those areas is not clear, but they could have either bilateral symmetric sacroiliitis, or more often they would have asymmetric, which means either one side affected, the other one isn't, or one side is affected more than the other side. It's a matter of getting x-rays or other imaging done, like MRI. And basically, if you're a dermatologist, I would send the patient to a rheumatologist and let them worry about it.
Great. That's absolutely a good tip. Okay, so there is a question on, is nail involvement usually asymmetric? I have my own views on that, but I also wanted to hear what Dr. Gladman have to say on that too.
Well, again, people don't read the book. So it could be quite variable. We have a number of people that present with nail lesions in exactly the same fingers on both sides, but I would say that the majority of the patients probably present with asymmetric nail involvement. And in fact, not all the nails are involved. Obviously it's going to be symmetric when most of the nails are involved, but most of the time, to my mind, it is asymmetric.
Yes, I would agree with that. In my clinical experience too, most having done some nail studies and having to do NAPSI scoring and so forth, in most cases they do tend to be asymmetric, but obviously it differs from patient to patient, and I see a significant proportion presenting with symmetric involvement as well, but very rarely having sort of a 20 nail involvement with the crumbling and so forth. So I agree with that. Okay. All right. So Dr. Gladman, we have other comments as well. Dr. Kaplan commented on the AXIS study for psoriatic spondylitis. And Dr. Winston is asking a question. Can you comment on the spinal fracture in spondylitis?
Well, hold the spondylitis question for the next session. But these are uncommon in psoriatic arthritis.
Yes, great. That's a great reminder. We'll hold that. And then Dr. Tsuji asked, do systemic therapies have predictable differential effect on manifestations of psoriatic arthritis, such as skin, nail, enthesitis, joints?
Nothing is predictable in medicine. So some of the drugs that we use actually do work for both. Like most anti-TNF agents work for both skin and joints. But again, every patient, has their own body, and therefore it doesn't work for everybody. We know that anti-IL-17 agents work for both skin and joints. We know that the CTLA-4 Ig may work for the joints, but doesn't really do much for the skin. Tofacitinib doesn't work as well for the skin as it does for the joints unless you use double dose. And even etanercept, while it works really well for the joints, you need to use double dose for it to work closely better for the skin. So it very much depends on the drugs and on the patient.
Yes, and I would completely agree with what Dr. Gladman has said as well. There have been a few head-to-head studies looking at, for example, IL-17 versus TNF inhibitors in the treatment of psoriasis and psoriatic arthritis using both ACR primary endpoint as well as PASI primary endpoint. And what has been shown in at least 2 studies is that some of our IL-17 agents, such as secukinumab and ixekizumab, when you look at the combined endpoints, they are superior to our TNF inhibitors, adalimumab. And most of that superiority is really coming from the skin data. And when you look at the joint data, they're pretty comparable. So our IL-17s do seem to work as a class overall for psoriasis than the TNF inhibitors. Okay, And with that, we're going to get one more question out of Dr. Gladman. Some of my colleagues always call inflammatory arthritis rheumatoid arthritis if there's a positive rheumatoid factor or anti-CCP. And when I try to convince them otherwise, what additional clinical factors should I use? Are they correct? Does it make a difference?
So originally, psoriatic arthritis was described as seronegative. However, the study that produced the Caspar criteria demonstrated that 5% of the patients had a positive rheumatoid factor. My earlier studies show that it's even higher, but it was also present in patients with psoriasis without arthritis. So as patients get older, they're going to have a positive rheumatoid factor. But the clinical features that we've described actually are giveaway. For example, DIP joints are not common in rheumatoid arthritis. In fact, if they are affected, it's usually osteoarthritis, complicating the rheumatoid. Dactylitis is not a feature of rheumatoid arthritis. Patient has dactylitis, not likely to be rheumatoid arthritis. Maybe both, which could happen 1 in 10,000. And then the enthesitis is not a typical feature of rheumatoid arthritis either. So patient has enthesitis, think psoriatic arthritis. The back involvement is not a feature of rheumatoid arthritis. Patient has spondylitis, not likely to be rheumatoid. Although originally, all spondylitis was called rheumatoid spondylitis. But we now know, or we've known for the last 50 years at least, that rheumatoid arthritis patients do not actually present with inflammatory axial disease. So there are lots of clinical features that help us distinguish even in a patient who has a positive rheumatoid factor. And remember, the Caspar criteria, you don't get a point for having, you don't detract point for having a rheumatoid factor. You only don't get a point if it's positive.
Great, thank you for that. All right, so now we're going to proceed to the psoriasis section, and please keep asking your questions. You can keep asking about psoriasis or psoriatic arthritis in the chat function, and we'll address them at our next Q&A session. And before we do that, we're going to take a look at the pre-questions. So here we go. Which of the following is a dermatologic emergency? Is it severe intertriginous psoriasis, widespread guttate psoriasis, severe nail psoriasis, or erythrodermic psoriasis? You have about 10 seconds. All right, we're going to close in 4, 3, 2, 1. All right, looks like most of you answered erythrodermic psoriasis. Next question, please. Which of the following is a feature of palmoplantar pustulosis? Is it predominance of hyperkeratotic plaques on the palms and soles, associated with HLA-CW6, associated with heavy alcohol intake, or associated with plaque psoriasis in 20% of the cases? And we'll close the poll in 4, 3, 2, and 1. All right, so most of you answered predominance of hyperkeratotic plaques on the palms and soles. All right, so we'll stay tuned to see what the correct answer to these questions are, and then we will go on to our next talk that's given by me. Hello, I'm Dr. April Armstrong. I'm Professor of Dermatology and Associate Dean at the University of Southern California in Los Angeles. I'm very excited to talk to you today about psoriasis, focusing on its epidemiology, classification, and clinical features. I run our department's clinical studies unit, and here are my disclosures. Let's start with a question. Here are 2 patients. One of them has psoriasis. Can you correctly identify which one? If you identified person A on the left as having psoriasis, you're correct. Person B on the right has leprosy. The diagnosis of psoriasis can be confusing in some cases. In fact, if we lived in Roman times, many psoriasis patients would be sent to quarantine at leprosy colonies. Compared to psoriasis, leprosy lesions tend to be less scaly. And, as you heard from our patient research partners Suzanne and Wendy earlier, the impact of psoriasis and psoriatic arthritis is substantial. Therefore, accurate diagnosis and classification of psoriasis is highly important. Today, we will discuss epidemiology, pathogenesis of psoriasis. We will also identify psoriasis subtypes and common clinical presentations. Finally, we will provide a brief overview of the comorbidities associated with psoriasis. Approximately 125 million people around the world have psoriasis, and its prevalence varies depending on the region. Psoriasis prevalence is highest in Western Europe, followed by Central Europe, North America, and South Latin America. Psoriasis prevalence is relatively lower in East Asia and Australasia. In the United States, where I live, psoriasis affects approximately 3.2% of the U.S. adult population and less than 1% of children. That amounts to approximately 8 million people affected with psoriasis in the United States. The prevalence rates of psoriasis in Europe and Russia vary between 1.5 to over 3%. Psoriasis prevalence in Africa is not well characterized and is thought to be below 0.5%. In Asia, the prevalence rates are estimated to be 0.4%. Psoriasis occurs in equal frequency in both sexes. 75% of patients will have onset of psoriasis before age 40. In adults, there are two peaks of onset. First one between 20 to 30 years of age, and that's the most common type. Most people who present with psoriasis in adulthood will present during that peak. There is a peak later on at between 50 to 60 years. In children, the onset is typically between 8 to 12.5 years. The prevalence is between 0.5 to 1% in children below 16 years of age. Psoriasis has a strong genetic basis. Here are the various HLA subtypes that have been associated with psoriasis. Notably, HLA-CW6 confers a high risk of developing psoriasis in Caucasians and the Japanese. HLA-B26 has been associated with pustular psoriasis, and HLA-B13 and B17 have been associated with gouty psoriasis in children. Based on this classic European study on families with psoriasis, if both patients have psoriasis, a child has 50% chance of developing psoriasis. If one parent has psoriasis, a child has 15% chance of developing psoriasis. So, what is going on in the skin? This JAMA review paper that our team published talks about the pathogenesis of psoriasis. Overall, psoriasis is based on a feed-forward inflammatory model. Myeloid dendritic cells are critical in this process. Once activated, they migrate to the lymph nodes. There, they secrete IL-12, which enables differentiation of naive T cells into Th1 cells. Or the myeloid dendritic cells can also secrete IL-23, which is highly important in psoriasis. IL-23 is critical in the differentiation of naive T cells into Th17 cells, which then secrete downstream cytokines such as IL-17 and TNF-alpha, among others. These inflammatory cytokines further drives and perpetuates this inflammatory cycle, which leads to keratinocyte proliferation and infiltration of lymphocytes and neutrophils. Exogenous triggers and exacerbating factors of psoriasis include infection, especially with streptococcal infection, hypocalcemia, psychogenic stress, certain medications, as well as obesity, alcohol consumption, and smoking. Now, let's talk about the important topic of different subtypes of psoriasis. The classification of psoriasis can be either based on morphology, what the lesions look like, or based on location, where they are on the body. Using the morphology-based classification of psoriasis, plaque psoriasis is the most common subtype. Other subtypes include guttate, erythrodermic, and pustular. Dermatologists also use location-based classification, referring to subtypes as inverse or intertriginous psoriasis if they occur in the skin folds, palmar-plantar areas, or nail psoriasis. It's very important to recognize two features of these classification systems. First, there can be overlap of morphology-based and location-based classification in the same individual. For example, a patient may have plaque psoriasis on the arms and inverse psoriasis. Second, a patient can also change from one subtype to another, for example, from guttate to then progressing to plaque psoriasis. So it is important to recognize this fluidity and don't get yourself frazzled if you cannot put a patient neatly in one subtype. Now, let's talk about plaque psoriasis. Plaque psoriasis is the most common subtype of psoriasis, representing approximately 80% of the phenotype. It is characterized by well-demarcated plaques with varying degrees of erythema, scale, and induration. Does psoriasis itch? It can, especially in patients with extensive plaque psoriasis or plaque psoriasis involving the scalp. Guttate psoriasis presents with eruptive confetti-like 3 to 5 millimeter patches on the skin. It commonly occurs following streptococcal pharyngitis. Guttate psoriasis may progress to plaque-type psoriasis. Guttate psoriasis occurs more commonly in children than adults. Before the onset of guttate psoriasis, there's often a history of infection with group A beta hemolytic strep of the pharynx and occasionally of the perianal area. In kids especially, guttate psoriasis is associated with streptococcal infection, and this association may be a good thing because when it's associated with streptococcal infection, it is more likely to spontaneously clear than those without the association with streptococcus. Erythrodermic psoriasis refers to confluent red skin due to psoriasis. Patients typically present with warm red scaly patches covering almost the entire body surface area. It is important to consider differential diagnosis for erythroderma, which include drug reaction, cutaneous T-cell lymphoma, or atopic dermatitis. Erythrodermic psoriasis is considered a dermatological emergency because patients can experience alterations in body temperature, fluids, and electrolytes. Pustular psoriasis typically presents as sterile pustules on the background of red skin. Pustular psoriasis can be divided into localized or generalized subtypes. Localized subtype can occur on the palms and soles. Generalized pustular psoriasis, or GPP, is a rare and serious skin disorder that presents with acute flares of widespread pustules. This is also a dermatologic emergency. Typically, the skin is fiery red at first, and then within hours, 2 to 3 millimeter pustules appear. There may be associated fever, chills, myalgia, electrolyte imbalance, and high output cardiac failure. GPP was found to be associated with recessive IL-36 receptor gene mutation. Because GPP can be life-threatening, hospitalizations are generally required to manage body temperature, electrolyte imbalance, and fluid loss. Before we talk about location-based classification, let's take a look at this chart showing the distribution of psoriatic lesions on the body. Not surprisingly, scalp and extensor surfaces are commonly affected. Genital areas can be affected in 33 to 63% of patients. Inverse psoriasis can occur in about 1/3 of the patients, and palmar-plantar psoriasis is present in about 12% of patients. For example, extensive scalp psoriasis can extend along the hairline, as you can see in these two photos. Inverse or intertriginous psoriasis involve the skin folds, such as inguinal, perineal, genital, intergluteal, axillary, or inframammary regions. Because it involves the skin folds where it is more moist, inverse psoriasis or intertriginous psoriasis presents with smooth, shiny plaques with absent or minimal scale. Inverse psoriasis is oftentimes mistaken for fungal infections. Palmar-plantar psoriasis is an entity with varying morphology. The most common subtype presents with thick, hyperkeratotic plaques. The pustular variant, called palmar-plantar pustulosis, has incited some controversy in terms of its classification. While some consider this to be a subtype of palmar-plantar psoriasis, it is regarded by many as a distinct entity from psoriasis. This is because palmar-plantar pustulosis is not associated with HLA-CW6, which is the main genetic determinant of plaque psoriasis. Palmar-plantar pustulosis is strongly associated with tobacco use and can be very challenging to treat. However, it is associated with plaque lesions of plaque psoriasis elsewhere in about 20% of patients, and therefore it is considered by some as still a part of the spectrum of psoriatic disease. Here are some photos of the palmar-plantar psoriasis, the hyperkeratotic subtype. Psoriatic nail disease has a prevalence of around 50% among patients with psoriasis, but some studies suggest a higher prevalence. Nail psoriasis may be associated with psoriatic arthritis, and the treatment of moderate to severe nail psoriasis oftentimes requires systemic treatments. Pitting is the most common psoriatic nail finding. This is a manifestation of psoriasis affecting the nail matrix. However, pitting can also be seen in other diseases, such as alopecia areata and atopic dermatitis. When you see numerous pits, for example, greater than 10 pits on 2 nails, that is more suggestive of psoriatic nail disease. Oil spots are more specific for psoriasis. When psoriasis affects the nail bed, it results in separation of the nail plate from the nail bed. This then results in a yellowish discoloration that looks like an oil spot. In severe cases of psoriatic nail disease, crumbling of the whole nail plate can be seen. Finally, one area that is important to know is that psoriasis is independently associated with a number of different comorbidities, including psoriatic arthritis, cardiovascular and cardiometabolic diseases, depression, and other immune-mediated diseases, such as uveitis and inflammatory bowel disease. Screening for these conditions is very important in patients with psoriasis. With that, I hope that you have found this talk on psoriasis epidemiology, classification, and clinical features to be informative. Thank you very much for your time. Go to the questions, and while we do the post questions, I would encourage the audience to continue to submit some questions in the chat. So let's go to the first post question. Which of the following is a dermatologic emergency? I'll have you read the answers there, and then we'll give you about 10 seconds for that. All right, 4, 3, 2, 1. All right, erythrodermic psoriasis. I'm going to discuss these as we kind of go along. So among the choices given, erythrodermic psoriasis is an dermatologic emergency because it oftentimes causes electrolyte imbalances. Patients can lose heat, and conversely, some patients can get quite feverish as well. I think widespread guttate psoriasis is recognized, but typically not considered as of a dermatologic emergency as erythrodermic psoriasis. In addition to that, of the types that I talked about, generalized pustular psoriasis is also considered a dermatologic emergency. Next question, please. Okay, next question. Which of the following is a feature of palmoplantar pustulosis? And we'll count down at 4, 3, 2, 1. All right, so I want to congratulate the 53% of you who was not put to sleep by my talk. So the correct answer here is the last one, associated with plaque psoriasis in 20% of the cases. Next slide, please. So as you see, the question asks, which of the following is a feature of palmoplantar pustulosis? So I know that many of you still chose A, which would have been the correct answer if the question asked which of the following is palmoplantar psoriasis. So if you hear the word palmoplantar psoriasis, they're actually, most of the time, is referring to the hyperkeratotic non-pustular type. But then the palmoplantar pustulosis is a separate, distinct entity. And as you can see here, so most people with palmoplantar pustulosis actually don't have generalized plaque psoriasis, and that's why only 20% are associated with generalized plaque psoriasis. And its genetic associations are actually thought to be very distinctive from that of the generalized plaque psoriasis. So thank you for that. I see a lot of you have improved on the second question. So now we will go to our panel. And I'm going to wait for our staff to bring the panelists on. So we have Dr. Gladman back, and then we also have, I want to just introduce everyone to Dr. Hellawell, who is a professor in rheumatology at University of Leeds from the United Kingdom. And like Dr. Gladman, Dr. Hellawell was a past president of GRAPPA, and he also has a keen sense of humor, named GRAPPA and PEST and a bunch of other things. So we're very fortunate to have him here. So welcome, Professor Hellawell, and also I want to welcome back Suzanne as well to our panel. All right, so the first question goes to Dr. Hellawell. Dr. Hellawell, do you believe that early use of biologics in psoriasis can prevent the development of PSA?
I really would like to believe this. It makes sense and it would make life a lot easier. And there is emerging evidence from observational studies that this is the case. There have been at least 2 series which suggested that. And there was a small study in Leeds which looked at the use of ustekinumab and its effect on subclinical enthesitis, which was also positive. But against it, we all see patients who come to us on biologics with psoriasis who develop joint problems, sometimes psoriatic arthritis. So it's obviously not true for everybody. And there was a series of 100 patients from Naples in Italy, which were people presenting with new onset psoriatic arthritis already on anti-TNF drugs. It would be very difficult to prove this point, obviously, but I really would like to believe that was true.
Great, thank you for that. So we will stay tuned for I know a lot of ongoing efforts are looking at that question, and I would say I would like to believe in that as well. All right, let's ask Suzanne, if you can let us know, you talked about rheum-derm collaboration, and if you could change one thing about how we currently collaborate, what would it be from a patient's perspective? Would it be, seeing a rheumatologist and dermatologist at the same time, or something else?
Yeah, I think that'd be really helpful. I guess I sometimes question why I'd seen many dermatologists, and that was partially because I was moving because of school and career, and no one had ever mentioned to me psoriatic arthritis. So I think if there was just more collaboration, more communication, that could be very helpful.
Great, thank you for that. And then sorry about that. That's what happens in the pandemic when you have to share an office with your husband. All right, so let's go to some of the questions for me there. So thank you for all these questions. So the first question, so one of the questions, what tips do you have for rheumatologists referring spondyloarthritis patients with skin involvement to dermatology? I would say, you know, dermatologists we're pretty kind of straightforward. So I will just let us know what you suspect as one of the diagnoses, and then you can, whether it's psoriatic arthritis, whether it's reactive arthritis, you can just let us know, and we will examine the skin. So I would say really very little is needed. For reactive arthritis, oftentimes we also look for signs such as erythema nodosum. In males, we also look for things like balanitis cercinates. And in addition to that, we also look for things like keratoderma planoalgicum. So as long as a dermatologist is one who will do a thorough exam and is pretty competent in medical dermatology, I think I would say really no special information needed other than letting us know what type of spondyloarthritis you may be thinking of. Okay, next one, what is the correlation of oral steroids in the development of guttate psoriasis? Is there a role of strep pharyngitis in it? So oral steroids and development of guttate psoriasis is not very well characterized, as you heard in the talk. Most of it is really concerning pustular psoriasis. So I think that is continually being studied. Next one, historically the use of oral prednisone in patients with PSA is frowned upon due to the risk of rebound in psoriasis or pustular psoriasis, and the recent literature may downplay that. What is your take? Would you be okay using oral prednisone at low doses to control flare or PSA? So my take that if you really need low-dose oral prednisone to control PSA, I'm actually a little bit less militant about that. And the key thing is really the tapering, the quick withdrawal of the steroids. If someone is started, for example, on steroids, a high dose, and then that's quickly tapered off, that's where the risk is the greatest with regards to psoriasis flare. So I would say as long as it's tapered, and if you're using a really cautious, judicious dose, I think that's something that if you can work with your dermatologist, I think it can be managed. All right, can you speak more about what therapies would be offered for psoriatic nail disease that persists despite of systemic therapy? I would ask about the type of systemic therapy that's used. Believe it or not, prior to the advent of biologics, and we used to inject the nail matrix, which is considered really a torture for our patients. And these days, with most biologics, it actually works pretty well. So for patients with a moderate to severe nail disease, systemic therapy should be considered first line. If that's not helpful, can you inject the nail matrix? Yes, you can, and there are particular injection techniques I probably may not have too much time of going into at this time. But you do, I would say very few dermatologists do that now. One can also apply high potency topical class 1 topical steroids to the nail matrix region to try to control that. But I would say not nearly as effective as systemic therapy. All right, and let's see here. I think I addressed most of this. And there is the talking about nail pitting again. So nail pitting can be seen in psoriasis and as well as a number of other conditions in dermatology. For example, you can see nail pitting in alopecia areata as well. Typically, nail pitting in psoriasis, there are, compared to other derm conditions, there are more of nail pitting. Nail pitting can affect both hands, typically affecting the hands. Nail pitting affecting the feet is actually a lot less commonly than the nails of the hands, than the fingernails. All right. So with that, we're going to move on to the third session, which is axial spondyloarthritis. So if we can queue up, and I want to thank our panel, Professor Hellawell, Professor Gladman, and Suzanne for their participation in this session. All right, so for axial SPA, the first question, what is the approximate male to female ratio among recently diagnosed patients with axial SPA? Is it 4:1, 2:1, 1:1, or 1:2? And we'll count down at 4, 3, 2, 1. All right, so it looks like most of you thought it was 2:1, then some of you thought it was 4:1, so we'll stay tuned. Next question. All right, next question. What would be your next diagnostic step in a 53-year-old patient with chronic back pain, acute anterior uveitis, HLA-B27, and slightly elevated CRP? I'll have you read the answer choices. And we'll have the polls close in, oh, sorry. Okay, I was gonna count down. All right, so let's take a look at this. So most of you chose imaging of sacroiliac joints. All right, stay tuned. Next, please. And we'll go to the talk by Professor Khan.
My name is Muhammad Asim Khan. I will describe the epidemiology of XPA and review its prevalence expressed as a percentage and its incidence expressed as the number of persons who develop the disease per 100,000 individuals. This busy slide shows some of the recent studies from North America and Europe. Please only focus on the bold letters and numbers among the 5 studies that use the ASAS and the modified New York criteria. The prevalence markedly varies, and the numbers that are underlined indicate the prevalence range from 0.3 to 1.3% for XPA as a whole, 0.12 to 0.8% for AS, and it is 0.17 to 0.57% for non-radiographic XPA. The global prevalence as determined by a systematic review and meta-regression analysis shows a wide variation from as low as 0.02% prevalence in sub-Saharan Africa to as high as 0.35% prevalence in northern Arctic communities, while the prevalence in Europe and North America is quite similar. There are many native tribes that live in North America, and they have been studied for the prevalence of AS as shown on the next slide. Almost a half a century ago, Gofton reported that Haida native tribe living on an island in British Columbia, a province of Canada, has a 6% prevalence of AS, while many of the other tribes listed on this slide have a much lower prevalence. I am very familiar with the last two studies as I was one of the advisors for this US-funded project performed in collaboration with the former Soviet Union. These two studies are the best, and they reported a 0.4% prevalence of AS among the Inupiat and Yupik Eskimo tribes that live across both sides of the Bering Sea, and a 0.53% prevalence among the Chukchi tribe in eastern Siberia. This is the global map that shows a 50% prevalence of B27 among the Haida and 40% among the Inupiat and Yupik tribes. Please also notice a very high prevalence of B27 among all these circumpolar communities up north as compared to the rest of the world. Interestingly, there is a virtual absence of B27 and AS among the indigenous natives of unmixed ancestry in South America and southernmost part of Africa and Australia. As a consequence of the European colonization, the current prevalence of B27 is shown in red-colored numbers. Also, please note that the prevalence of B27 in Japan is less than 1%, actually 0.5%. The incidence of AS also directly correlates with B27 prevalence. As a result, AS is very uncommon in Japan with a 0.48 mean annual incidence per 100,000 population that has a 0.5% prevalence of B27. This contrasts with many times higher annual incidence in the other two populations listed on in this table that also, and these populations also have many times higher prevalence of B27 in their population. Ankylosing spondylitis is more common among men, whereas non-radiographic XPA is more common among women. And also non-radiographic XPA has a later age of onset and a weaker association with HLA-B27. Switzerland has seen a gradually progressive decline in male to female ratio among patients with XPA from a ratio of 2.6 to 1 in 1980 down to 1-to-1 ratio by the end of 2016 as a result of the improving disease recognition and the use of newer disease criteria. The small red arrow on the world map points to 5 to 12% prevalence of HLA-B27 in Indonesia. The 5% figure is for the Chinese Indonesians, and up to the 12% figure is for the Indonesian native population. But ankylosing spondylitis is more prevalent among the Chinese Indonesians. Now we know the answer for this paradox because the native Indonesians mostly possess B2706 subtype, one of the 224 subtypes currently known, and this subtype is mostly disease neutral. In other words, it's not disease associated in Indonesia among the native Indonesians, while the Chinese Indonesians possess the HLA-B2704 and 05 subtypes that are disease associated. In mainland China, B2704 subtype carries even a higher risk for AS than the 05 subtype. B27 also influences the disease phenotype, and the B27 positive patients clinically differ from those that lack B27. In conclusion, there are marked differences worldwide in the prevalence and incidence of XPA, variation is greatly influenced by genetic factors, primarily B27, and other undefined factors, and the classification criteria used for the studies. And XPA is still under-recognized, especially in women who more often have a non-radiographic XPA form that has a later age of onset and a somewhat weaker association with B27.
Ladies and gentlemen, my name is Denis Podubny. I'm a rheumatologist in Berlin, Germany, and it's my pleasure to talk today about diagnosis and classification of axial spondyloarthritis. I'm sure that you are very well aware of the others classification criteria for axial spondyloarthritis. This criteria can be fulfilled if a patient with a diagnosis of axial spondyloarthritis presents with chronic back pain that started before 45 years of age and has either sacroiliitis on imaging in combination with at least one additional spondyloarthritis feature, or HLA-B27 positivity with at least two additional spondyloarthritis features. Importantly, the classification criteria should not be used for the primary diagnosis of the disease, and there are several substantial differences between the diagnostic and classification approaches. Here they are. First, the aim of the diagnostic approach is to establish the diagnosis of a disease in clinical practice. The aim of the classification approach is to define a homogeneous group of patients for research purposes. Therefore, the starting point in the diagnostic approach is a suspicion of the disease with a certain level of pretest probability, while the starting point of the classification approach is the established diagnosis of the disease. Consequently, differential diagnosis or other conditions that might explain patient symptoms are always considered when making the diagnosis, but are not considered in the classification approach. In the diagnostic approach, we consider both positive and negative results of diagnostic tests, while in the classification approach, we only tick boxes indicating positive test results. Finally, the outcome of the diagnostic approach is a diagnosis of a disease with a certain level of probability, while with the classification approach, we receive yes or no answer with a certain level of sensitivity and specificity. The diagnostic approach can be depicted as a diagnostic scale which weighs positive test results against negative test results. Importantly, the weight of a positive result might be different from the weight of a negative result of the same diagnostic test. For instance, definite high-grade radiographic sacroiliitis has a big diagnostic value if it is present. However, the absence of radiographic sacroiliitis has not that much weight because the disease can be at the early stage. Important is also the big black ball here indicating the presence of a more likely explanation of symptoms. Those weights can be expressed in numbers if we calculate positive and negative likelihood ratios of different diagnostic tests as depicted here. It is important to stress, however, that the performance of different diagnostic tests can be different in different settings and is dependent, for instance, on geographic region and referral pathway. Imaging is the only way of objective confirmation of inflammatory affection of the axial skeleton in a patient with clinically suspected axial spondyloarthritis. According to the Euler recommendation for imaging in axial spondyloarthritis, conventional radiography of sacroiliac joints is recommended as a first imaging method if the disease is suspected. If the diagnosis of spondyloarthritis cannot be established after conventional radiography or radiography cannot be applied, MRI of sacroiliac joints would be the next imaging procedure. MRI of the spine doesn't add too much to the MRI of the sacroiliac joints in spondyloarthritis, but might be relevant for differential diagnosis. In the clinical practice, there are two MRI sequences which are normally sufficient to confirm or to exclude the presence of sacroiliitis as a manifestation of XL-SPA. The first one is a T2 weighted sequence with fat suppression, such as STIR sequence depicted here. The purpose of this sequence is recognition of active inflammatory changes, bone marrow edema. The second sequence is a T1 weighted sequence, which is helpful in detecting structural changes caused by inflammation, erosions, fat lesions, sclerosis, and ankylosis. For a better depiction of erosions, you might consider including in your routine MRI protocol a special cartilage sequence such as WIPE, and you don't need gadolinium for the detection of sacroiliitis. According to the others definition of positive MRI of sacroiliac joints, active sacroiliitis compatible with SPA is defined as clearly present bone marrow edema that is localized in subchondral bone and is highly suggestive of spondyloarthritis. This definition was developed for the classification purposes, but describes very well our current understanding of active sacroiliitis compatible with SPA. In the diagnostic approach, we also consider structural changes which indicate the presence of inflammation in the past. It might be relevant, therefore, for making the diagnosis. Let me illustrate the diagnostic approach in a real patient example. This is a young male patient, 27 years old, who presented to a rheumatologist because of low back pain for approximately 3 years. There were some features indicative of inflammatory back pain, but no peripheral and no extramuscular skeletal manifestations. HLA-B27 was positive and CRP was only slightly elevated. In this case, we have a young B27 positive subject with chronic back pain and slightly elevated CRP that makes axial spondyloarthritis one of the most likely explanations of back pain. In order to confirm the presence of axial spondyloarthritis, we performed radiography of sacroiliac joints first. This is so-called Ferguson view, normally allowing for depiction of the upper portion of both sacroiliac joints. With the exception of some sclerosis in the left sacroiliac joint, there are no pathological changes here. The next step is therefore MRI of sacroiliac joints, and here you see the STIR sequence with bright water and dark fat signals. On this sequence, we are looking for the presence of bone marrow edema. Indeed, bone marrow edema is clearly present here, localized in a typical anatomical area, and is large enough to be seen on several consecutive slices. In order to be sure that this bone marrow edema is really related to axial spondyloarthritis, let's have a look at the T1 weighted. T1 weighted sequence is characterized by the bright signal from fat and dark signal from water. Here we can see structural changes compatible with axial spondyloarthritis, subchondral sclerosis, fat metaplasia, and erosions. On this background, we can be sure that bone marrow edema seen on the previous slide is related to axial spondyloarthritis. In summary, the diagnostic approach in XLSPA is based on a careful evaluation of positive and negative test results in the context of the pretest probability and other potential explanation of symptoms. Classification criteria should not be used for establishing the diagnosis. Imaging for the objective detection of inflammatory changes plays one of the most important roles in the diagnosis of axial spondyloarthritis, and of course, imaging findings should always be considered in the clinical context. Thank you very much for your attention.
All right, so let's go to the post questions. The first one is, what is the approximate male to female ratio among recently diagnosed patients with axial SPA? All right, we're gonna, in 5 seconds, close the polls. 5, 4, 3, 2, 1. Okay, and the next slide, please. So the correct answer here is 1-to-1 ratio, male to female. All right, next question. What would be your next diagnostic step in a 53-year-old patient with chronic back pain, acute anterior uveitis, HLA-B27 positivity, and slightly elevated CRP? Okay. And then in 5 seconds, we're going to close the poll. 5, 4, 3, 2, and 1. All right, and looks like the majority of you, 93%, are correct. Next slide, imaging of the sacroiliac joints is the correct response. With that, we're going to bring our panelists to the discussion now. So we have a number of different questions, and we will, I would like to also introduce Dr. Philip Meese here that you see on the screen. Dr. Meese is a clinical professor at the University of Washington School of Medicine in Seattle, and he is also director of the Rheumatology Clinical Research Division at the Swedish Medical Center, and he's also past president of GRAPPA. So as you can see, really, we have a star-studded panel here, so welcome, Professor Meese. And then I welcome back Professor Gladman, and I hope Dr. Khan can join us. I know he has a little bit of internet connectivity issues right now. So with that, we'll go right to our audience's questions. First question is, can non-radiographic axial SpA be present even without MRI evidence? Why don't we start with Professor Meese and with that question?
So the answer is yes, and it can be by two different methods, I would say. So in the official ASAS criteria, a patient could have a positive B27 gene marker, and then at least 2 characteristic spondyloarthritis features, and don't need to have any imaging changes, but could be classified as having axial spondyloarthritis. I will also add to that sometimes in clinical practice, we will see patients that don't quite fit. They're not the right round item fitting into a circle. They just don't quite fit, and they, for all intents and purposes, have an axial spondyloarthritis, but may not have proper imaging. Right now, we're doing a fascinating study in which we're looking at validating and or revising the classification criteria. And there are a number of cases that we're discovering that may have clinical features that are very convincing and respond quite well to therapy, but may not fit in. I also want to just comment on the questions. I noticed that in the beginning, when you asked the pretest question that Professor Khan had put there, that the majority of the respondents had said 2-to-1 or even 4-to-1 male to female, but by the time the post-test questions came around, they corrected themselves to 1-to-1, acknowledging the fact that there's been a gender justice issue going on with an under-recognition of female patients in this population. And Asim pointed that out, and people clearly heard him that that's the case now.
Great. Thank you very much, Professor Meese, for that. I'm not sure if Professor Khan can hear us. Can you hear us, Professor Khan? Okay, seems like not. We're hoping that he will join us. But next question, I'm going to ask Dr. Gladman, which is in the chat here. So Dr. Gladman, what are the common causes for bone marrow edema on MRI of SI joint other than non-axial SpA, and can increased exercise or NSAIDs used prior to MRI have any effect on these radiographic edema?
So increased exercise certainly can do it. Pregnancy can do it in terms of bone marrow edema as causes of non-rheumatologic conditions. NSAIDs actually would make it better rather than de novo initiate these changes.
Great. Well, thank you for that. And then we'll do the last question. I'll throw that to Dr. Meese here. Dr. Meese, would you make a diagnosis of spondyloarthritis in a young HLA-B27 positive subject with typical inflammatory back pain, but no abnormalities on MRI of the SI joints and spine?
So I see we come around to that question again. It's obviously
yes,
something that is on people's mind. And because this is a difficult area for us, I will say that we really appreciate and depend upon X-ray and especially MRI scanning, as Professor Kadudny so eloquently described, for having greater confidence in the diagnosis. And I find myself putting a great deal of weight on it. But there are patients, as I mentioned, that either do fit in the classification criteria because of B27 positivity but negative imaging, or you just have a very strong gut feeling that they fit. And so we end up trying therapies and hoping that they benefit. And if not, then we need to look for another diagnosis. It also can be the case that a patient can have MRI positivity at certain times, but not at others. So I've seen patients where with flaring activity, the MRI will light up. And then if they are not flaring, it may not be lighting up. Or with treatment, their MRI findings may go away. So I think it takes some clinical acumen and a good feel for your patient to ascertain what is the true itis here and distinguishing it from mechanical or degenerative or fibromyalgia pain.
Great. Well, thank you very much for that insight. So I want to thank Professor Meese and Professor Gladman, as well as I know Professor Khan was trying to join, unfortunately couldn't be connected, but really appreciate all the great talks today. So with that, I'm going to excuse our panel and we're going to bring up our last set of slides. And as our technical team do that, I mainly wanted to really thank everyone for all of your participation today, the active engagement. Your questions have been such an integral part of our of this session for making this successful. And I would like to, next please. Yes, I would like to again thank Pfizer for sponsoring this global educational activity. And I think through this activity, I do hope that all of you will take some kernels that you can bring with you to your clinics tomorrow. And next. And I just want to let other people be aware of these upcoming seminars. As you can see, we have a number of different opportunities to learn more about genetics and pathogenesis, assessing disease activity, comorbidities, and burdens, as well as global perspectives on new therapy, in addition to the hot topics. And I really appreciate everyone's comments and everyone's engagement. And it really has been a really enjoyable session, I think, for all of us. Again, I want to thank our panelists, but very importantly, I want to thank our audience for your time today. Have a great night.